But eventually, if it is not going to respond to conventional DMARDs, it won't respond to egrotimod also.
Right. And is there
It's the opinion all over Kerala, actually.
Okay. And any specific reason why, means from safety profile point of view, will you prescribe egrotimod?
So far I haven't faced any.
Tablet.
Yes. So far I haven't faced any problem with egrotimod. Occasionally, a couple of them have developed some viral infections, but then now it is more like a protected scenario using the mask and all those things. But sulfasalazine, we cannot predict the allergic reaction. So, but the response is less than that of sulfasalazine. That is what I have found. It is not that predictive like sulfasalazine, HCQ, or methotrexate. If it works, it works. Otherwise, it won't. It's very hard.
Very hard.
I don't know. Like maybe if you wait for 3 months or something like that, maybe there might be some response. But starting the conventional DMARDs in the initial phase itself, there will be some response which is not shown like that promisingly with the egrotimod.
Okay. Because leflunomide or maybe sulfasalazine or maybe hydroxychloroquine, they start showing in within 1 month, I think, around 1 month.
Yes.
But egrotimod is taking time as per your experience with the molecule.
Yes.
We have also launched. So just
I came to know Xyramod.
Yeah. But that's why I'm asking so many questions. I just wanted to know the real knowledge or real experience with the molecule.
It's been almost 4 months since I have started using it.
After being promoted by Redimad, actually.
Yes.
Even other companies have started. I think noise level will increase now, and there will be addition of this molecule.
But the awareness among orthopedicians and other physicians are less. They are surprised to hear that there is another DMARD which they don't know.
That's why we called it as a novel DMARD. But rheumatologists know that it's not that novel. It's there in the market from last 1.5 years. Right. Absolutely right.
Are you guys starting this phosphodiesterase inhibitor, apremilast?
No, we
Psoriatic
are not. Psoriatic arthritis, okay. So is going to be helpful for us? What you suggest?
There are patients who benefit from apremilast in psoriatic arthritis.
It's a good market. Means from our point of view, it's a good business market. It has a good acceptance.
Right now, I'm using from the one from IPCA as well as from that Wallace Pharmacy. They have shown good result, but the side effect profile is little high. Not like the dangerous, but gastrointestinal effects are little troublesome for the patient.
Right. Only good thing about egrotimod is that it has some safety, though it has little less efficacy.
Yes.
But it's an equation with every molecule.
Maybe because we are not. Yes.
It's an equation, I think, in medicine that if it is a very safe molecule, that means it has a little less efficacy or the potency. Even, for example, we have launched one PPI, like esomeprazole and all those PPIs. They are very safe, but if you see the efficacy compared to pantoprazole and rabeprazole, it comes less as well, always. Those may be the reason. Even I think etrodolac was one of the NSAID. Nobody uses it because potency is little less. Everybody goes for aceclofenac then. Potency and even safety is little better.
1 second.
Yeah, sure, sir. We have 4 minutes to go. 6 minutes left.
Your kids.
They are making a lot of noise in the background, and it's very embarrassing.
No, that's a part and parcel of life now.
But this is something like at least state level program we are doing, so need to be a little careful. I don't used to come here. That's the reason, because of her only, my daughter. I used to do it at my home, but today there is
Now
some
daughters
program
are a little more, and they are a little more naughty than boys.
than the boys. Yeah, that era has gone, and now they are come.
Even I
Are you
have a
having?
daughter.
Yeah, that's why I was supposed to ask that. You must be having daughter. They're very notorious, and they're far smarter than the boys I see nowadays.
Hmm.
36 registrations were there. 730.
That's a good number.
Yeah, it's a good number, but we always strive hard in the last
Yes.
half an hour actually, so that we can at least
Yeah, mainly now the
expect
number of webinars are going up and up. So
large number. Actually, better we should keep it on weekdays. Weekends are absolutely packed.
yes, yes. Today itself there was one rheumatology webinar on back pain. So
Okay. Bye.
already like yeah, I don't know. It's an all India meet
Okay.
on back pain. Yeah.
Okay. Okay. That is the purpose why actually we are actually conducting all these webinars locally. That's the thought we have given.
So we will be live in a minute.
Yeah, I know.
Okay.
I know. Yes. Yes.
Yeah.
Yes. So I'll share the presentation. You must be knowing Dr. Mujib Rahman as well, right?
Yes, yes.
He was also there with us, I think 15 days back.
Okay.
It was very successful program again.
We are live, sir. So we can start, sir.
Yeah, thank you very much. So good evening, everyone. Good evening all for joining us today on this wonderful webinar platform. We called it as a Ruma DG Conclave. So on behalf of Zydus, I welcome you all for Ruma DG Conclave today. We are having with us today our guest speaker, who is a renowned consultant rheumatologist, Dr. Vishnu S. Chandran. Welcome, sir. And
Thank you.
thank you very much for taking your precious time out today for us and for entire audience, so that we can get some knowledge about today's topic, which is very interesting: approach to arthritis. Moreover, Dr. Vishnu S. Chandran, he is a founder of Rheumatology and Clinical Immunology Department in Believers Church Medical College, Tiruvalla. I would like to go a little more detail into his introduction. Once again, Dr. Vishnu S. Chandran, he is a consultant rheumatologist. He is a young and dynamic rheumatologist who is the founder of the Department of Rheumatology and Clinical Immunology at Believers Church Medical College Hospital, Tiruvalla. Moreover, Sir has received the Best Poster Award for his work in rheumatoid arthritis at World Rheumatology Forum conducted at Gurgaon in 2019, and he has a publication and paper on Behcet's disease. Sorry if I'm pronouncing it wrong. Behcet's disease, as well as IgA vasculitis. So I welcome you, sir, and I really thankful on behalf of entire Zydus Synovia family that you have taken your time for all of us, not only for Zydus but for all the audience who is going to benefit it today with the very interesting topic, which is approach to arthritis. So over to you, sir. I'll just unshare this presentation and then you can share your presentation. Thank you, sir. Over to you, sir.
Thank you, Vishal, for the kind introduction. And thank you, Cyrus Group, for giving me this opportunity. So, Can you see my
Yes, sir.
PowerPoint?
Yes, sir. Your presentation is visible, and
So
you can continue, sir.
thank you. So let me first introduce to this picture where we all, as the early humans, believed that the Earth was a flat object and we were living on it, walking on it, until we saw the subtle features, like subtle clues like that of the disappearing mast of the ship, which is disappearing at the end of the horizon, or the sun, which is traveling through the atmosphere. These were subtle clues which initially gave us the identity that our Earth was not flat and it was more of a round object. With this, let me start my presentation. The approach to the patterns of joint pain. Why I didn't put it as an approach to arthritis? Because the pain is a symptom with which most of the patients OP clinics, and the objective of my presentation today will be to identify the structures that are involved in the pain, the pattern recognition for each type of pain, the red flag signs, and the role of biochemical and radiological evaluation in coming to a conclusion. Pain is a subjective sensation. Most often, all of us have experienced pain. It is having multiple domains. One is the subjective sensation of pain, then the emotional domain, where you are thinking that you have to suffer this pain, and the social domain, where your relatives or the family members have an acceptance degree in this pain. Most often, we have to understand that the pain is a subjective sensation and it cannot be felt or seen by another person. There are other clues to see this pain. For this, we have to understand the first step to understand the pain or arthritis, where the pain exactly is, whether it is a generalized pain or a regional pain. Most often, the patients come to you with a complaint of pain all over your body, but you have to put in leading questions to understand whether it is definitely a generalized pain or is it confining to a particular regional area. The second question is when the pain is, that is when it is more, whether it is associated with an activity or whether it is in the resting phase, and the relationship to the pain. Most often there are inflammatory pain which starts in the early morning hours or wakes you up from sleep. Also, a generalized pain like that of fibromyalgia can have association with sleep, making you lose your sleep, and it is not understood by your partner. Then there are other associations like which are definite for arthritis and inflammatory conditions, which are swelling, stiffness, restriction of movement. The systemic symptoms like fever, weight loss, loss of appetite, and the presence of a past history is most important. There may be family history, there may not be family history, but it is also very relevant. Now, coming to the regional pain syndrome, which are the specific group, mainly the arthritis, are pains in pain to a particular region of musculoskeletal area. These articular symptoms are mainly close to the joint capsule, which may be due to a joint damage or due to inflammation. Periarticular pain is mainly located to the anatomical structures that are helpful in movement of a joint but are located outside the joint capsule. The neurogenic pain is a pain which is due to the involvement of the nerves, which are either the peripheral nerve, the plexus, or the nerve roots, or even the central nervous system. The referred pain is a pain which is originating from a visceral organ and totally unrelated to the joint or the periarticular structures. Now, coming to the periarticular pain, this is the first step of identification of the region of pain involved. That is where exactly the pain is. This periarticular pain is often an inflammatory pain, which is due to a repeated trauma or a local manifestation of a systemic disease like that of crystal arthropathy. The pain is often elicited by specific movements, and not all movements are introducing pain to the patient. The pain will be more to an active than a passive movement, and the pain will be exaggerated by application of resistance to the particular movement. There will not be any pain when you are applying pressure over the joint line. However, articular pain is the true arthritis or arthralgia, which is occurring because of an inflammatory or a non-inflammatory pathology. The movements will be painful, both for active as well as passive movement. And there will be restriction because of the swelling or a structural damage. The swelling often is the restricting factor here. Most often the patient will pose a position which is in the loose back area, that is where there is minimal amount of pressure in that affected joint, whereas pain will be maximum when you apply pressure to that capsule and stretch the capsule. The pain will be elicited by palpation over the joint line or the margins of the joint, and it will be often associated with a systemic symptom, at least like that of fatigue, weight loss, or even excruciating extreme weight loss or fever. The characteristic features of the joint involved are mainly of an inflammatory pathology will be stiffness and gel phenomenon. The stiffness is more or less early morning stiffness that is experienced immediately after getting up from sleep. And a gel phenomenon is described as a pain that is experienced by the patient on getting up from rest. Even non-inflammatory pathology like osteoarthritis can have stiffness and gel phenomenon, but it will last for lesser duration. Inflammatory pathology will be having a pain more than 30 minutes, whereas the non-inflammatory one will be less than 30 minutes. And the gel phenomenon will last more than 5 to 10 minutes in an inflammatory pathology. Swelling is the definite symptom of articular pain. The patient, articular disease. The patient will come with complaint of swelling affecting multiple joints, and it will be elicited by the examining doctor also. Due to the structural damage, predominantly to the muscles and the tendons, there can be weakness that is experienced by the patient. It can be either due to damage or by the swelling itself causing an inflammation. Fatigue is a symptom more often to that of an inflammatory arthritis due to the inflammatory milieu released into the systemic circulation. But patients with non-inflammatory pathology can experience fatigue because of the amount of exertion they take in doing their day-to-day activity. Severe joint damage and restriction of joint movements can lead to loss of function of the due to an articular symptom. To identify joint pathology, a simple MCP squeeze or an MTP squeeze would be ideal to identify even the early rheumatoid arthritis. Specific signs like the 3-finger test and 4-finger test can elicit the swelling, and which is more specific for a definite articular symptom. This cannot be elicited by other conditions like that of the periartitis, where there won't be definite elicitable swelling in the joint line. There can be swelling in the over the tendons, over the muscle group, or in other adjacent structures like the cyst or ganglion. Next is neurogenic pain. This is often something which is confusing that of an articular symptom, predominantly that of the that which is involving the carpal tunnel, causing a carpal tunnel syndrome. The patient will come with a typical stiffness, which is involving the small joints of the hand, making it difficult to make a fist. This symptom will also be more in the early morning hours. Why this is happening? Because of the compression of the hand or the compression of the nerve on the hand which they are sleeping on. And these pain will make them get up in the late night, and they will describe the pain as that of a dysesthesia, like burning, pins and needles, electric shock-like sensations. These are triggered by specific movement or specific joint positions, like that of sweeping, or those who are using computers can have pain after using the computers. Women who are driving on a bike can experience this paresthesias while applying accelerators or driving for a long time. And a central nervous system pain can be triggered by coughing or straining. It may or may not be associated with muscle wasting, because it is a progressive disease which is going to cause muscle wasting and weakness, and which is not always in the initial part of the neurogenic pain. Referred pain is something which is a pain which is not involving a joint or a periarticular structure, but it is a pain arising from the viscera, which is referred to its particular dermatome. It can be triggered by the physiology of the viscera. For example, pancreatitis pain, which can be elicited at the back as a back ache, and it is exaggerated by a fatty food. Now coming to the generalized pain syndrome. This is the most common with which most patients present to our OPD. It will be diffuse, excruciating pain all over the body. Often it is migratory or affecting a particular side of the body. It can be worsened by stress like cold, sleepless nights, or emotional trauma. And the pain will be experienced more after doing the exercise, not like during an exercise in a musculoskeletal disease or a mechanical pain, or like an inflammatory pathology which presents with an early morning stiffness, a pain before starting a particular job. It is often associated with other features like a tension or migraine headache, irritable bowel syndrome, pelvic pain syndrome, irritable bladder, and often these patients present to us with complaints of low mood, depression, anxiety, and you have to ask them. If you ask them, they will say that they often sit and cry alone because of the pain. This generalized pain syndrome can be an association of an organic disease also, like an inflammatory arthritis. Fibromyalgia is not the only diagnosis for generalized pain, but I'm not going into the details of that. Like a common disease of thyroid disease or inflammatory or an infectious disease should always be ruled out before labeling it as fibromyalgia. Now, the second step in identifying arthritis is defining arthritis. That is, whether it is an inflammatory or a non-inflammatory pathology. Like I said, already we have mentioned the characteristic features of an inflammatory pathology or non-inflammatory pathology. Next is its temporal pattern of the disorder. That is, whether it is acute, subacute, or a chronic disorder. The acute disease will start suddenly and it will be overnight, like that of a crystal arthropathy, which I'll be discussing later. Whereas a chronic arthritis exists more than 6 weeks and go over time, involving multiple joints in an additive or a spontaneous fashion. Next is a spatial pattern that you have to identify whether it is a monoarthritis, oligoarthritis, or polyarthritis, depending upon the disease presentation at 6 months of the disease. You should not be very early to diagnose it as a poly or oligoarticular disease because it will take at least 6 months to evolve into a proper arthritis. There can be axial joint involvement and other extra-articular and systemic manifestations which will give more clues towards a diagnosis, coming to a complete diagnosis. Now, let's go to the first case. This was a patient who came to me. He was 64-year-old and he came to me with complaints of pain involving his first metatarsophalangeal joint over the right foot. It started 1 week prior to his visit and it was most excruciating on the day of presentation. The pain improved over time by application of heat or cold, and it was not going completely. This made it difficult for him to walk over time. So he came to me and he told that he had similar complaints of pain occurring couple of years back, and he had good response to NSA. His lab evaluation showed that it was an inflammatory pathology with a high CRP and ESR. His CBC was normal. LFT showed only mild SGPT elevation. His renal functions, uric acid, ASO titers, rheumatoid factor, and CCP all were negative. Now, most of us would have been tempting to put a diagnosis of hyperuricemia or gout, but seeing the uric acid levels, it would have been difficult for most of us. With this, let me go to the first pattern, the spatial pattern, that is monoarthritis. The most common cause of an acute inflammatory monoarthritis is a crystal synovitis. It should be ruled out that the septic arthritis is a close differential, but those are these features like a rapid onset of disease, which is worst in the first 6 to 24 hours, with severe pain on the time of at the time of presentation. The pain will be so severe that they will tell that it was difficult for me to cover my body with a bed sheet. they had florid, they would have had florid synovitis with swelling involving the adjacent structures and mimicking that of a cellulitis. There, there may be episodes of self-limiting episodes in the past, and it can be associated even without taking any medication or application of. So this is a typical picture of a clinical crystal arthritis. However, there are two differential diagnoses which are most commonly seen to differentiate the crystal arthritis, even though basic calcium phosphate crystals are also seen as a crystal arthropathy. The gout is more common, and the first episode will often be in the night, and the first metatarsophalangeal joint is most often involved. Other joints like the ankle joint, the knee joint, or the or the midfoot are commonly involved. There won't be any trigger most often, but some of them have, some of the patients will recognize a triggering factor like a high calorie diet, drink before the night of onset of the disease, etc. And there can be systemic features in a severe gouty arthritis, which will make it difficult to differentiate from a septic arthritis. A pseudogout calcium pyrophosphate disease is also a similar crystal arthropathy, but it is restricted to the age group above 60 years. And it can be seen most often in the wrist, knee, shoulders, and ankle. To diagnose gout, the EULAR has made certain recommendations, and they have not given the emphasis on finding hyperuricemia alone in making a diagnosis of gout. They have always emphasized that a search for crystals in the synovial fluid is the most appropriate thing to do to identify a gouty arthritis. If it is difficult, like if it is difficult to aspirate the joint, then it will be better to go for the clinical characters like the monoarticular involvement, especially in the MTP joint, the ankle joint involvement, a previous episode of acute arthritis with worst pain at night, and in the male gender with cardiovascular or hyperuricemia in the past. Why it is difficult to identify gout with hyperuricemia? Because most often during an acute attack, there will be increased production of IL-6, which can cause uricosuriia, which will reduce the serum levels of uric acid. If there is a confusion in identifying gout with absence of any definitive crystals in the synovial fluid, the presentation, then you have to go for radiological help, radio diagnosis. That is, with the help of a Doppler, a power Doppler or an ultrasound scan, we can always find that there's a double contour sign over the cartilage, or even dual energy CT can help in the identification of crystals of monosodium urate. There should be always a search for chronic hyperuricemia, that is chronic kidney disease, obesity, metabolic syndrome, medications like calcineurin inhibitors, low dose aspirin, diuretics, and proper diet history is mandatory. Systemic assessment of these patients are also important, and always rule out urolithiasis or nephrolithiasis in these patients. There are different stages of gout, and most often we experience gout in the most often we experience gout with gout flares or intervertebral gout. Chronic gouty arthritis will be present like that of a polyarticular disease of rheumatoid arthritis or psoriatic arthritis, etc. But often they will have adjacent joint, adjacent to the joint, there will be cellulitis or tendon involvement, which will make it more easy to diagnose. So the steps will be search for monosodium urate crystals, a clinical diagnosis, and if it fails, then go for imaging. Septic arthritis, on contrary to crystal arthropathy, will have a pain which is progressive with associated symptoms of fever, chills, fatigue, cachexia, etc. The joints will be often destroyed, and it will be most often associated with another disease. A chronic septic arthritis will be little more difficult than an acute disease, like that of tuberculosis. I have seen patients with chronic tubercular arthritis being treated as inflammatory chronic arthritis. And brucellosis, borreliosis, and fungal arthritis are other chronic arthritis which are difficult to diagnose. Now coming to a second case. This is a 35-year-old male who presented to my OP with complaints of pain which started in the left ankle and eventually started involving the right middle finger MCP joint. Eventually, he had a left shoulder pain also with difficulty in external rotating. He had a swelling which was affecting the entire right middle finger and of that of the right second toe. On detailed evaluation, it was found that he had a patch over the hairline, which was simulating that of psoriatic arthritis. Now, the diagnosis of psoriatic arthritis is still pending, which comes to clinical arthritis presentations, that of oligoarthritis, polyarthritis. Oligoarthritis is described when there are more than 2 joints and less than or equal to 4 joint involvement. Polyarthritis is described when more than 4 joints is involved, and it is often in a symmetric or an asymmetric fashion. It can be either additive or migratory. A chronic additive symmetric polyarthritis, a pattern is often seen in rheumatoid arthritis. The pattern involves involvement of more than 5 joint involvement lasting for more than 6 weeks, and small joints of the hand and feet are the ones most commonly involved. It can even start in a large joint like that of the knee, the wrist, which are going to progress over time in an additive fashion involving the other joints, making it an additive symmetric polyarthritis. There may be systemic features like fatigue, cachexia, weight loss, fever, and other systemic features which can confuse the patients as well as the clinician. The other causes of additive symmetric polyarthritis are SLE, Sjogren's syndrome, mixed connective tissue disorders, and inflammatory myositis. Even viral arthritis can sometimes mimic an additive inflammatory polyarthritis. Coming to additive asymmetric arthritis, it can be described as an oligoarticular asymmetric disease or a polyarticular disease, where more than 2 joints are involved, and it is associated with other additional features like dactylitis, enthesitis, DIP joint involvement, and the disease most often will start from an ankle joint. These patients will be seronegative, and it comes to it leads to the diagnosis of common presentation that for psoriatic arthritis, reactive arthritis, sarcoid arthropathy, a seronegative peripheral spondyloarthritis, Behçet's disease, polyarticular gout, CPPD, and even vasculitic disorders. Rheumatoid arthritis is the most common cause of an chronic inflammatory polyarthritis. It is an additive symmetric arthritis which is having a more female predilection, and it is seen in a young female. Not that it cannot be seen in an elderly male or a elderly female. It is of an insidious. It has an insidious onset with predominantly the small joints of the hand and feet involvement. It typically spares the distal interphalangeal joint of the hand because it is not of a synovial joint. Morning stiffness is a cardinal symptom in most rheumatoid arthritis. The axial joints are also spared in rheumatoid arthritis for the same reason that the synovial joint is seen only in the atlantoaxial joint, which makes it more predominant and more predilection for a rheumatoid arthritis. There are other different patterns of rheumatoid arthritis like that of a palindromic rheumatism. It is an episodic arthritis which occurs in a migratory fashion involving one joint after the other, and it lasts only for a few hours to days, and it follows a palindromic pattern, making it difficult to diagnose as a rheumatoid arthritis. Rheumatoid factor and anti-CCP can be positive in palindromic rheumatism, and eventually the patient may evolve into a full-blown rheumatoid arthritis in the presence of this serological positivity. Arthritis robustus is a typical pattern which is seen in manual labors where there is not much of a joint destruction because of their physical exertion. Now, how do we diagnose rheumatoid arthritis? It is based on a classification criteria, the ACR and EULAR combined released in 2010. This was used to enroll patients into research where they had more than one joint involvement in an inflammatory pattern with synovitis not explained by another disease. Based on the scoring system, based on a scoring system, the number of joint involved, serology, acute phase reactants, and the duration of the symptoms will help in diagnosis of rheumatoid arthritis. Here it is very important to notice that a serology is not mandatory in the diagnosis of rheumatoid arthritis. The number of joints with the duration and an acute phase reactant involvement in a typical clinical scenario can help in the diagnosis of rheumatoid arthritis. In contrast to the previous 1987 ACR classification criteria, the 2010 classification criteria helped in identification of early rheumatoid arthritis because rheumatoid nodules, radiological change, and the symmetrical presentation can all be seen in the later stage of rheumatoid arthritis who are not properly treated to target in the early phase of the disease. This is the typical presentation which is shown by the ACR 1987 criteria, where there is a swan neck deformity, this deformity, rheumatoid nodules, which can even produce rice bodies like rice bodies which can extrude from the periarticular area. However, this is the common presentation where there will be metacarpophalangeal and PIP joint involvement. They can present with even an asymmetric fashion in the initial phase, but eventually it will evolve into a symmetric additive polyarthritis with typical early morning stiffness involved in the hand and feet. Like the picture initially I showed, a metacarpophalangeal joint squeeze test is very helpful identifying the early disease and early synovitis. Here we have a picture of a rheumatoid hand where you can see that there is marginal erosion seen in the metacarpophalangeal as well as in the DIP joint with juxta-articular osteopenia seen in these patients. And there is no ankylosis because it's an early disease which is treated partially. And now coming to the role of laboratory, that is the serological diagnosis. Mind you, it is not rheumatoid arthritis factor, it is rheumatoid factor, and it is an immunoglobulin which is directed against the FC portion of the immunoglobulin G. It is a non-specific test. It does not help in the diagnosis per se of rheumatoid arthritis. It is seen only in 70%, and hence the sensitivity and specificity is very low for rheumatoid factor. 5% of the normal individuals can also have rheumatoid factor positivity. A high titer of rheumatoid factor is something which is very important in the diagnosis of rheumatoid arthritis. On the contrary, anti-CCP or citrulline peptides can have a high sensitivity, specifically the ACPA, which is helpful in the diagnosis of rheumatoid arthritis. But even in the absence of this serology, it can be diagnosed based on the clinical characters pertaining to rheumatoid arthritis. The importance of these serological factors are that to predict the severity of the disease, and these severe diseases can have a propensity to involve extra-articular regions like the lungs, the eyes, or even present with the pyoderma. And it is very important to try to target these patients with a poor prognostic factor. There are other serological factors other than this rheumatoid arthritis, which are the anti-CARP antibodies, RA33, which are all seen in 30% of those patients who are seronegative in the initial phase. But those are not commercial, and hence I have not included in the presentation. Rheumatoid factor positivity is seen in other diseases like Sjogren's syndrome, SLE, where the rheumatoid factor titers will be low. Mixed connective tissue disorders can have rheumatoid factor positivity and a clinical picture simulating that of rheumatoid arthritis. Cryoglobulinemia and vasculitis are something which can have some disease which can have rheumatoid factor positivity in almost 99% of disease, and makes it more helpful in diagnosis of those diseases. Infectious diseases like infective endocarditis and chronic infections can also have rheumatoid factor positivity, making it a non-specific diagnostic tool. Next, coming to psoriatic arthritis. It is a member of the spondyloarthritis which have inflammatory pathology associated to the joint associated with psoriasis. It is seen in 2 to 3% of the psoriatic of the general population, and seen in 42% of psoriatic skin disease patients. Plaque psoriasis is the most common presenting skin symptom, and the skin manifestations may not be visible in many of the patients in the initial period because of the involvement of the topical treatment. But nail changes are most commonly seen, and it cannot be missed in a detailed clinical evaluation. It is diagnosed based on the Casper criteria, where there is importance given to the current psoriasis, personal history of psoriasis diagnosed by a dermatologist or a rheumatologist, and a family history involving first and second generation. But often it is not told in the initial few visits by the patients. Nail dystrophic changes are given another weightage in the diagnosis of psoriatic arthritis. Then a negative rheumatoid factor is very important in the diagnosis of psoriatic arthritis, and most common cause of seronegative arthritis can be a can be a psoriatic polyarticular disease. Dactylitis can be visualized, and it may not be painful. Juxta-articular newborn formation or osteitis is a common presentation in rheumatoid in psoriatic patients. There are different patterns of joint involvement in the psoriatic arthritis. This include the asymmetric oligoarthritis, symmetric polyarthritis, which is the most common presentation, making it difficult to differentiate from a rheumatoid arthritis. There can be DIP joint involvement, but it is less than 5% of the patients, and it can also involve the sacroiliac joint or the axial joints, but it is in association with HLA-B27. Arthritis mutilans is very, very rare. Here, this is a patient who presented to me with the predominant DIP joint involvement, where you can see that there is definite soft tissue swelling with the marginal erosion, and you can also notice that there is periosteal reaction to these patients for her. She also had clinical features of psoriasis and nail changes, which made the diagnosis possible in the first visit itself. She had to be injected in the DIP joint because of an excruciating pain in that DIP joint. This is an elderly male who presented with large chunky osteophytes seen in the axial spine, as well as a destroyed elbow joint with periosteal reaction and a newborn formation, which can be seen in the elbow joint. The margins of the joints and the articular surface was completely lost, and the biopsy from the synovium showed that there was inflammatory process going on. Arthritis mutilans is a common presentation it's not a common presentation in psoriatic arthritis, but it is worth mentioning. It involves only the appendicular joints, and it is not the one which involves the axial joints. There will be a clinical criteria and radiological criteria to fulfill the diagnosis of arthritis mutilans. It is a rapid onset disease, but it was not included in the criteria, and there will be shortening of the digital telescoping or a flail joint, not due to subluxation. There will be definite erosion of the articular surface with a penicillin cup appearance due to the newborn formation on the either side of the opposing articular surface. Spondyloarthritis is a heterogeneous group of disease which involves the mucous membrane as well as the joints, which can involve either the axial or the appendicular joint. The hallmark of the disease group of disease is axial spondyloarthritis or ankylosing spondylitis with sacroiliac joint involvement. It is typically seen in the third decade of a male who presents with low backache with alternating buttock pain, but it is not uncommon in the childhood. A boy of more than 6 years can have similar presentation with enthesitis, and it is called as an enthesitis related arthritis, juvenile idiopathic arthritis. It involves both of axial as well as peripheral spondyloarthritis, and it is overlapping in all the possible combinations. And axial disease is divided into a radiographic and non-radiographic spondyloarthritis, and it makes it difficult to diagnose in a non-radiographic ankylosing spondylitis. The concept of non-radiographic spondylitis and radiographic spondylitis is that the initial conventional radiograph cannot be helping in the diagnosis of inflammation in the sacroiliac joint, but there can be evidence of active inflammation in the sacroiliac joint, predominantly in the iliac bone, near the synovial joint. And eventually there will be radiographic sacroiliitis and syndesmoid formation. It takes years before the appearance of a radiography ankylosing spondylitis, and hence there will be a lot of misdiagnosis in the early phase of the disease. The typical clinical pattern of the disease will be an asymmetric nature, the absence of rheumatoid factor, absence of extra-articular manifestations of rheumatoid arthritis or autoimmune connective tissue disorder. And it is always very important to identify the family segregation of the disease and presence of HLA-B27. It is not mandatory to diagnose the disease with HLA-B27 positivity alone. So when to call it an inflammatory backache? It will be the first clinical presentation of insidious onset in the lumbosacral region with gradual gradual episodic and a persistent nature. The improvement on NSAID is very typical, and it is important in diagnosis of an inflammatory backache. The morning stiffness and the nocturnal pain, which makes a patient difficult to roll over on the bed, is very important to notice. And there will be low backache, which is improving on exercise, which is very important to notice. So the first pattern recognition should be a inflammatory pathology, that is low backache, early morning stiffness, and improvement on exercise. There won't be improvement at rest. These patients will have onset of disease before the age of 45 with additional features like enthesitis. Mainly, there will be Achilles tendonitis or heel pain and chest wall enthesitis. These should be the leading questions which should be asked the patient to identify an inflammatory backache. They will have difficulty while taking a deep breath or coughing. They can also have uveitis, scleritis, episcleritis, and a family history of similar presentations, especially in the male gender. There can be IBD like presentation where they can have alternating loose stools with blood in stool occasionally seen. Psoriasis is also an additional factor which you have to always ask, unless and until you ask, the patients won't give you a history of psoriasis. So how to identify or diagnose the case of spondyloarthritis? First of all, identify whether there is a back pain which is lasting for more than 3 months. Then there should be a search for sacroiliitis or presence of other features of spondyloarthritis, like the corner shiny corners, like there is the Romanus sign or that of the Anderson sign, which is seen on a MRI, or the presence of an HLA-B27. And in the presence of these two, you have to always search for arthritis, heel enthesitis, dactylitis, uveitis, psoriasis, Crohn's disease, or ulcerative colitis. And a response to NSAID is very important. Family history is very important. There will be an elevated CRP, and ESR may not be that much elevated. Another clue will be an elevated alkaline phosphatase, which is seen predominantly in spondyloarthritis. Peripheral spondyloarthritis will have arthritis, enthesitis, or uveal involvement with at least MRI or HLA-B27 positivity in the presence of other clinical and disease features seen in these patients. Sacroiliitis detected in an MRI does not need a contrast enhanced MRI. A simple stir image of the sacroiliac joint shows that there will be a involvement of the synovial portion of the iliac bone, and it should be seen in more than one slice of the image taken. And radiological image can also show that other features are like the Romanus sign and the Anderson sign. Now coming to HLA-B27, it is a gene with a high susceptibility to ankylosing spondylitis. It is seen in 95% of the patients with ankylosing spondylitis and in 60% of those with enteropathic arthritis or psoriatic arthritis. Not all patients with HLA-B27 will develop the disease. The presence of HLA-B27 is not mandatory for the diagnosis also. And what is the importance then? It is important to see whether there is an HLA-B27 positivity, to see whether there is a chance of recurrence of the disease in the family, or to assess the response to TNF inhibitors and other conventional synthetic demands also. Even though there are some data on that there are less response to HLA-B27, they can also have a partial response to to TNF inhibitors. Now coming to a differential diagnosis. These are two similar picture, one of that of ankylosing spondylitis and the other one that of closed differential diagnosis. Here we can see that there is a chunky osteophyte which are seen like that of a wax which is flowing out from a burning candle. This is of the diagnosis of a disease called as dish. It is helpful to diagnose this based on the typical picture. That is, in dish it will be waxy candle wax appearance, whereas in ankylosing spondylitis it will be a bamboo spine appearance where there will be squaring of vertebra, which is not seen in dish. And another feature which is helpful in differentiating dish from that of ankylosing spondylitis is that there will be always a hump seen at the end of the edge of the articular surface, or something like that of a T. AP view of the thoracolumbar spine will also help in the differential diagnosis of dish from that of spondyloarthritis. There will be at least 4 consecutive spine which is involved here in diffuse idiopathic skeletal hyperosteosis, like a candle wax appearance seen only on the right side. Why it is not seen on the left side? Maybe because of the pulsating aorta. That was the explanation. And it is most often seen in association with an uncontrolled diabetes, hypertriglyceridemia, hypothyroidism, etc., and other metabolic conditions with the proliferative bone disease. Proximal oligoarthritis is another disease which is helpful, which is very important to differentiate from that of a distal oligoarthritis, like that seen in spondyloarthritis. A proximal oligoarthritis is very important, like because it mimics other diseases like polymyalgia rheumatica, periarthritis, osteoarthritis, and Behçet's disease. Osteoarthritis is a non-inflammatory arthritis which is occurring mainly in the elderly age group, but it can start from the 40s and involve predominantly the knee, hip, and can get worse over time. The nodal osteoarthritis is another pattern which is predominantly seen in women with a family history of similar presentation. They can have the DIP and the NCP joint, DIP and the PIP joint involvement with Heberden and Borchardt nodules, with typically pain present over those joints and swelling seen on either side of the joint. Atypical OA is described when there is a young age of onset of osteoarthritis and unusual joints involved. All those joints which are marked in gray are unusual joints, like the elbow joint, the wrist joint, the ankle joint, and the shoulder glenohumeral joint. These are atypical for osteoarthritis. You should always search for another diagnosis. A typical nodal arthritis, that is nodal OA, can present with a seagull appearance on a radiograph, which is there will be central erosion with periarticular osteophytes seen on either sides, like that of a seagull. And on a hypertrophic OA, where there will be hypertrophy of the hypertrophic syndesm of osteophytes seen on either side of the knee joint, typically seen. But it should be always mandatory to look for additional signs like that of a presence of calcium pyrophosphate deposition inside the joint, which can present as an acute inflammatory arthritis in osteoarthritis patients also. Juvenile idiopathic arthritis is an inflammatory arthritis which is of childhood. Often this disease will be starting before the age of 16, and it will last for more than 6 weeks. To classify the disease, we have to observe the disease for more than 6 months to classify it in a particular group. And always we have to look for the common causes of arthritis like infections before classifying it as juvenile idiopathic arthritis. The ILAR has classified it into systemic juvenile idiopathic arthritis, or previously known as the Still's disease, with features of fever of quotidian fashion, rashes over the body, sore throat, hepatosplenomegaly in association with arthritis, which can precede or come along with arthritis. Now, oligoarthritis, polyarthritis in association with rheumatoid factor positivity or negativity makes the other 2 criteria. Psoriatic arthritis mimic that of an adult psoriatic arthritis, but here the psoriasis part will be missed upon most often. ERA-JIA or the enthesitis related arthritis is the childhood counterpart of ankylosing spondylitis, and there is an undifferentiated arthritis classification group which does not fit into or fits into more than one group of juvenile idiopathic arthritis. So this is again the explanation the same. And what is important is that the oligoarthritis is divided into persistent oligoarthritis and extended oligoarthritis, depending upon the number of joints involved after the 6 months. If it is pertaining to less than 4 joints, it can be a persistent oligoarthritis, and if it is more than 4 joint involvement after 6 months, it will be an extended oligoarticular JIA. Why is it important to us identify these different patterns? Oligoarticular JIA, systemic juvenile idiopathic arthritis, polyarticular JIA, all in the presence of an ANA positivity have other extra-articular manifestations, especially those involving the eye. So it is very important not to forget the eye in kid who is coming with chronic inflammatory arthritis. Here is a patient who came with acute anterior uveitis and keratitis with because of arthritis which was not properly treated. His eye disease was identified actually by his grandmother when he was trying to find his footwear by searching on the floor with his hand. Now we should not forget the connective tissue disorder. This is a spot diagnosis where there is a child who presents with typical malar rash as well as oral ulcer. This is definitely SLE. Now we should not forget other features like that of a DLE where there are scarring skin lesions. This patient actually thought that it was allergic reaction to the hair dye. However, she was having arthritis and her ANA was positive, and her skin biopsy also proved that there was definite features of discoid lupus erythematosus. Now, it is very difficult to identify if you see this patient with arthritis, but if you closely see, there is photosensitive rash seen on the either side of the nose and also over the nose in this patient. Now, it is very important to ask this question, that is presence of Raynaud's phenomenon, and look for always the nail fold capillary changes. If you closely watch your nail fold capillary, nail fold region, you can see that it is dark. But in these patients with nail fold capillary changes, it is more or less pale. This is because of the reduction in the number of capillaries. This image on the which I'm highlighting now is taken by a mobile phone on its maximum magnification, where you can see that there are some amount of embolic phenomenon seen in the distal region. And upon magnification with the nail fold capillary, handheld nail fold capilloscope, you can see that there are embolic phenomenon, dropouts of some of the nail fold capillaries and widening of or enlargement of the nail fold capillaries. This is important in diagnosis of certain diseases like mixed connective tissue disorder, scleroderma, etc. And unless and until you look this, the patient is not going to tell you this. And additional features like that of skin thickening, salt and pepper pigmentation, digital tip ulcerations, digital tip gangrene, and ILD are important in diagnosis. Coming to the other clinical features, there will be systemic features like fever, weight loss, photosensitivity, skin rashes, oral ulcers, Zika symptoms, arthritis, cirrhosis, renal involvement in SLE, Sjogren's syndrome, and mixed connective tissue disorder. Whereas scleroderma or systemic sclerosis will have Raynaud's phenomenon as one of its predominant symptoms with digital tip ulcers, pitting, thickening of the skin, sclerodactyly, and GERD is one important symptom in these patients. They can have interstitial lung disease or dry cough, which is seen in the late night. They can have salt and pepper pigmentation like the one seen before, and even myositis, that is difficulty to get up from the sitting posture, is one important symptom in these patients. Like I said, scleroderma, like I said, in Sjogren's syndrome, Zika symptom is most predominant. And these patients can have RF positivity, but in a low titer, but have a very high ESI. Mixed connective tissue disorder, it is very important to look for Raynaud's phenomenon and diffuse finger swelling. ANA can be positive, and it is most often positive for a very high titer of U1 RNP positivity. And ANA by immunofluorescence, indirect immunofluorescence is the gold standard. Please do not send for ELISA because it can have a lot of false positivity and false negativity. These are images of, this is an image of a nuclear homogeneous pattern of 4+ intensity from one of our patients, and the other one with a speckled pattern, and the other one with a centromeric pattern. Why is it important to send an immunofluorescent can be explained by this. Because if you see a centromeric pattern, it is more or less confirmatory that the patient is having systemic sclerosis. And a speckled pattern can be seen in many conditions. Homogeneous is more or less diagnostic of SLE in the setting of a clinical scenario. When to order ANA is another question. For all patients, it is not mandatory to send ANA. Whenever there is a feature pertaining to that of a connective tissue disorder, like PUO, weight loss, loss of appetite, skin symptoms, Raynaud's phenomenon, serositis, pulmonary involvement, can be a pneumonitis, shrinking lung syndrome, ILD, and glomerulonephritis, which can be marked by proteinuria, hematuria, cast, and an asymptomatic pyuria is very important. Neuromuscular involvement is also important in sending an ANA. Raynaud's phenomenon is one of the important features in identifying a connective tissue disorder. There are various causes like drugs, chronic liver disease, immune lung disease, which can have positive, false positive ANAs. Normal people can also have a false positive ANAs, like that of a diffuse fine speckled or DFS 70 pattern. You should not miss out on vasculitis, which can present with inflammatory arthritis, but you have to look for subtle signs like that of a erythematous patch, vasculitic ulcers, which may be healed, paniculitis, etc. They have multi-system diseases with more of predominant systemic features like fever, weight loss, hypertension, renal involvement, etc. Behçet's disease is something very important which one should not miss because it is extremely rare but uncommon. Most often the patient will have a painful oral ulcer with pustulosis, and the patient may not explain a genital ulcer, which is most often painless. Sacroiliitis is one of the important presentation of Behçet's disease, and it can be falsely diagnosed as ankylosing spondylitis. They may not have an inflammatory marker which is positive. Now, what all are the lab investigations that you should send in the diagnosis of these patients? It is mandatory and always mandatory to send certain investigations like CBC, ESR, and CRP. Subtle clues can be taken from this. Anemia, leukopenia, cytopenia, thrombocytopenia, etc. are seen in SLE. And SLE patients will always have an elevated ESR, and CRP most often will be normal. While in spondyloarthritis, CRP can be elevated and ESR may not be elevated. In Behçet's disease, both can be normal, and CBC can also be normal. Eosinophilia is something very important in certain diseases like ANCA-associated vasculitis. In LFT, it is important to notice hyperglobulinemia. This means that there is some amount of inflammatory pathology. Urine analysis is important to look for, is important as it can show that there can be sediments, sterile pyuria, which shifts your focus to the renal involvement. Blood glucose is important. Conventional radiography is also important in the first visit. Special investigations include the serological factors, which I have already mentioned. HLA-B27 is important if you are suspecting a spondyloarthritis. HLA-B51 is something which is important in Behçet's disease. And in patients who are having cytopenia, peripheral smear, iron studies, and a Coombs test of direct or indirect nature is very important. Serum protein electrophores and light chain should be sent in specific situations like an elderly with hyperglobulinemia, high ESR, anemia, destructive joint lesions, and unexplained vein loss. Synovial fluid analysis is important to differentiate infectious pathology, and biopsy should always be sent without hesitance in case of a skin, renal, or lymph node involvement. Imaging is mandatory to look for soft tissue swelling, joint space narrowing, erosions, and erosions that are involving the marginal zone is more of an inflammatory pathology than that of a central erosion, which is hallmark of osteoarthritis. Crystal depositions and tophi can be appreciated in the conventional radiography in the chronic gouty arthritis. MRI should be ordered if there is an inflammatory pathology with not much of a conventional radiographic picture, which shows the early involvement with bone marrow edema, erosions which can be detected, and intra-articular and periarticular structural details which can give more value to your clinical care. Other imaging modalities like musculoskeletal system ultrasonography, skeletal scintigraphy, dual energy CT, and PET scan should be used wisely. So to conclude my speech, conclude my presentation, you should always ask the optimum questions. You should always listen to the patient properly and should avoid the background noise by asking leading questions. By doing so, you can have a proper investigation array, which also which also help you to avoid the background noise, like a proper pattern of investigation with the clinical scenario help to formulate a proper provisional diagnosis plan of management. And it is always essential not to repeat the serological test again and again, because normalizing them won't cure the disease, and it is only a reassurance for the patient or a distress to the patient if they are not improving properly. And always it is mandatory to treat to target. Thank you.
Thank you very much, sir. I must say it was really a wonderful, insightful, and very much in detail. Everything has been taken us through very much in detail. So thanks a lot, sir. Thanks a lot for enlightening us today with a lot of knowledge about approach to arthritis. Secondly, sir, I would like to take one question that has been asked from the audience, Dr. Deepthi. She's asking why ASO to be done, or why ASO done?
Yes, ASO is very important in a particular clinical setting. See, now ASO is a immunological reaction to a streptococcal infection. So those patients who are having a migratory arthritis with panicleitis or erythema nodosum, or a picture of inflammation, should always help in the diagnosis of an acute rheumatic fever. But in the absence of an acute rheumatic fever picture, it is not always mandatory to see an ASO titer. If at all an ASO titer is positive in a child who is having inflammatory arthritis of migratory picture, you should always look for the rise in titer or a change in titer, and that is very important in diagnosis. Otherwise, unnecessarily a high ASO titer does not say that it is an acute rheumatic fever.
All right, sir. And there is one more question, sir. What is your, the audience is asking your experience with the treatment of newly diagnosed ankylosing spondylitis patient?
So ankylosing spondylitis patient, as I said, axial spondyloarthritis is also there, and a peripheral spondyloarthritis is there. Axial spondyloarthritis experience a good response to NSAIDs, and it is very mandatory to put them on NSAID for a couple of months, because it helps in reducing the radiological progression of the disease, like formation of syndesmophytes, ankylosis of the joint, and it is used as a demon. And exercise is very important. A physical therapy is very important in control of the disease. Sulfasalazine may be helpful in a couple of patients. That currently, the as guidelines, the ACR EULAR guidelines all have mentioned the use of TNF inhibitors. Even though in the Indian setting, we still use sulfasalazine as a drug of choice in treating most of the disease. And peripheral arthritis, obviously, the response will be very good with steroids, NSAIDs, and other immunomodulatory therapy like methotrexate, sulfasalazine, leflunomide, etc. But again, in an inadequate response, you have to go for TNF inhibitors, IL-12, IL-17 blockers, IL-12, 23 blockers, etc.
Right, sir. So thank you very much, sir, for taking all our queries and solving it with the help of your own experience. So I must say, once again, thank you very much for such an enlightenment on approach to arthritis and very much in detail, not only the therapy part, but also you have touched upon the diagnostic part, which is much more in detail and important to be taken care in initial phase of any disease. So thanks a lot, sir. And thank you very much, everyone in the audience. Thank you very much for taking your time also for this wonderful session, Approach to Arthritis. And wish you happy Diwali to everyone in advance. Wish you happy Diwali to you, sir, as well.
Thank you.
Thank you very much and good night to everyone. Thank you, sir. Good night.